Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
Great. We just had our hand service research meeting, the first one for the year, and we got to share all of the fun things that we as faculty do. And then some reason it came down to team nerve versus team congenital. And your partner, Dr. Lindley Wall, suggested that while the nerve team may have more grants, your team has more publications.
I like how it got a little spicy.
Yeah, it did. And to be fair, I did evaluate very brief Goldfarb, CA, Wall, LW or LB, Brogan DM, and DCJ. And a very quick search showed it's very close. One team had 325, one team had 313. So say you average that out by years in practice, I think there's no contest.
What there's no contest about is that we are super dorky.
Yeah, well, that's who we are.
It
But
is what it is.
that was a fun first research meeting. We have a lot to talk about today. We're going to go through some requests from the grab bag, the survey. One about how we handle referrals, and then also there's going to be some nice tips and tricks on common surgeries. So we'll go through that. We'll summarize how things went at the Checkpoint Nerve Summit meeting that I went to, which was super fun, and I'm sure you'll get your fill of nerve more
Oh,
than enough
God.
today.
Yeah, I already got it in that research meeting. I will say the research meeting was super impressive. I mean, there is so much cool stuff going on here. You and David with, grant applications, the rest of us less so in that domain, but there's really great stuff going on. It's fun to be a part of it, and those meetings are, again, in a dorky kind of way, pretty fun.
Yeah, I will say, with the grants thing, because it's so hard to get federal funding nowadays, I decided I'm not just going to celebrate if we get a grant. I'm just going to celebrate if we turn in a grant. So it's been a busy time of the year. I submitted a grant for the REF in June and submitted a grant to the NIH last week. So I'm just happy to be done with that for now. And then the very, very long wait continues because we had a grant I submitted in March, another R1, and we're not going to find out a decision until October.
Ooh,
It's just torture.
that is definitely torture. Tell me about this Nerve Summit. Sounds super impressive.
It is super impressive. Thank you. So we got together in Cleveland. It was a group of about, I think, 25-ish peripheral nerve surgeons from across the country and across Canada. Got together, and I think this is the third year it's been going on. Last year was in Chicago, and our partners, Dave Brogan and Nate Olafson, were the key speakers. And then this year, the key speaker was Noah Raisman and Glenn Gaston, who shared pearls on coding for nerve injury or nerve surgery codes cases. Really interesting topics, and then great case discussions, both adults and then there was a peds breakout session. So just interesting to hear what's common struggles we have, how people do things a bit differently, how we all think of diagnoses and outcomes assessment differently. Just refreshing to see, how many different ways there are to do things. And obviously it was very fun to get into the nerdy nerve part of it.
So was this a day and a half or?
Yeah, so it was 2 half days. So kind of we started in the afternoon on a Friday, and then had a nice social in an old bank vault in Cleveland. Very cool. I have to say, people want to, say, well, why'd you go to Cleveland of all cities, and why are you excited about that? There was a lot to do. I found some really great bites, great food.
Sure, you did. Well, before we jump into referrals, let's thank our first sponsor. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Visit PracticeLink at www.practicelink.com/the upper hand.
So, referrals are interesting. And so there was a query about how do we handle referrals. And I don't know that I exactly know, but I think there's different ways we can go with this question. How do you think about it generally or specifically?
Yeah, so thanks to the listener that completed the survey and gave us a suggestion. The exact question was, or request was, I'd be interested to hear how you handle referrals both to and from other surgeons, both within the hand service and between other services. So some of that's I don't know if that's like a workflow thing of how you like to do it. But if there's somebody I particularly have in mind that I want to see the patient, I will send either an email or a message within our EMR, to that person with my specific query or leave a lot of breadcrumbs in the note itself. so that that person can try to pick up on what I'm asking for. Again, it depends if it's a highly specialized thing. So if it's a challenging patient, for example, that I will send to one of my senior partners, that's usually followed up with a phone call. Because I think that's just an easier and a more appropriate way to have that kind of conversation. But if it's more of a clinically routine thing that I just don't do enough of, then I'll send a note or actually just sometimes get the patient directly on the schedule if it's within our hand service.
Yeah, I think I have a lot of thoughts on this topic. I think it's a really good topic. And I'll start by saying once you get old, like me, everything gets a little easier because I'm a little more comfortable, and I'm a little more confident. And so I think about referrals in two ways. One set of referrals is if the patient just doesn't quite seem to be doing as well as I want, and you get that inkling that they're, maybe not thrilled. And I absolutely throw out there that, hey, I wish you were doing better. I'm not quite sure why you're not, but getting another opinion is always a good thing to do. And I will throw that out there. Thankfully, it doesn't happen all that often, but I think it shows confidence in what I've done and comfort with, sending it on. Now, I also have the built-in advantage of having amazing partners here at Washington University, but occasionally people want to go outside of WashU, and I'll give them names outside. But to me, that is a good thing to do. And if you lose a patient, because sometimes the second opinion, so to speak, is the right opinion, I think it's okay. And I think if the goal is to get the patient better and they're not progressing, sometimes that just makes a lot of sense. Do you do that, or how do you think about that aspect of it?
Yeah, I think that's super important. I think your earlier comments about how it becomes easier as you're more experienced is really, really, really important because that's a hard thing to do when you're starting out in practice. And you're probably going to be in that jam a bit more early on in practice just because you don't have enough years of experience to know kind of what recovery trajectories are supposed to look like. You're relying on what you've seen in theory, people should be doing, but that is a hard thing to do. Early on when you started, do you have any pearls about how to make that kind of suggestion that the patient sees somebody else without kind of undercutting your own expertise?
I don't know that I have any pearls. I would say that you have to do it with confidence, and it can't seem like you're punting or just trying to get the patient out of your office. Which every patient's not the same as far as ease of care. I don't really do that. I just think it has to be done with confidence and conviction that the message to the patient is, I want what's best for you. And I think another set of eyes, and I use this terminology, another set of eyes looking at you maybe invested differently in you, given that I've done a surgery on you, can be helpful. And sometimes they say, no, I love you. I'm staying here. I trust you. I say, thank you so much. And other times they say, I think that's a good idea. And you've done it right if they say, I think that's a good idea, because then it's not them abandoning you. And I think that's been helpful.
Yeah, I'm fortunate enough to have an easy line that I use, which is that I'll send the patient to a partner with a senior partner with either less hair or grayer hair than I do. Since my three senior partners all meet that criteria, I didn't include Dr. Wall in there since she only sees kids. But you, Ryan, and Marty all meet one of those criteria, and that usually puts a smile on their face. But I think it's really challenging. I can understand how somebody starting in practice now is really going to say, I don't know how I'm going to do that. When I was early on, I did send quite a bit, just because I just wasn't sure. And yes, it doesn't feel great in the short term for you, but I do think it helps in the long term, both for the patient and to know that you did the right thing. So that's how I would handle the challenging patient referral. Now, what if you're referring somebody to another orthopedic service?
Yeah, well, let me just finish this line of thought saying, and you know this, but I think the listeners should hear this as well, is that I definitely send you nerves, and I do that in situations where I just think you're better, able or more the correct person to deal with it. And I have sent you challenging outcomes. And I think that, despite the fact that I'm at a so-called high-powered institution, even within our group, that we have our areas of subspecialty interest, and there's value there. And again, to me, there's no shame in doing that at all. And it really is, it is a sign that you just want what's best for the patient, which I think we have to remember.
Yeah, and I think that's great. I've appreciated the folks that you've sent me, and I've definitely have sent you people as well that I don't have a great handle on, and your experience is better matched. I think it's important to maybe call your partners too if you're going to be sending them somebody in that situation, just because you can have a more appropriate conversation on the phone rather than trying to send out the perfect email because a lot gets lost in the written text.
Yeah, and then to the other issue is if you're sending someone to one of your partners, different specialty, or receiving a patient, I think it's important to find the balance between being 100% honest, but avoiding throwing anyone under the bus. And that's tricky. Again, I think a lot of my intra-departmental referrals is not so tricky because I think I'm blessed to have wonderful partners in all domains. But occasionally you see something where you wonder why it was done this way, and you don't want to be dishonest and you don't want to mislead a patient, and occasionally maybe it's I might have thought about this problem differently, but in general you just want to be honest but be careful in how you state things because sometimes patients are looking for an open door if they are does that resonate?
Yeah, it does. I mean, it makes a lot of sense. I see a fair number of not necessarily second opinions, but people that have had issues with other people and have found their way to me. And fortunately, there's a group of docs that that I've had good experience with the patients they've sent, and the patients I think have talked to them too, and then also hand therapists in the community have kind of will sometimes put a little buggy in patients' ears saying, think about going to see this person. But I agree, you completely have to handle it with a lot of poise because you don't want to drive a stake between the patient and the other doc. The other doc, if they refer directly, they're looking for help. And it's important to keep that in mind. And I agree. I say, well, I wasn't there, so I don't know. It's just everybody presents a little bit differently. I wasn't there. They say, well, did this happen during so and so? And say, I'm not sure. We'll never really know. And I've become more comfortable to your earlier point about saying I don't know a lot more in clinic. And that works for some people, but it doesn't work for some people, but for the vast majority of patients, it does work when they realize that I'm being honest with them. I tell them I don't know something, but I think here's what possibly, could be our options. But handling that relationship well. I have not been as good about calling referring physicians. And that's probably something where earlier on I definitely called referring physicians a lot more. I think there was obviously I had an interest in developing those relationships quickly, but I just haven't had the time in the day so far to make calls to referring docs as much. Unless they text or call me directly about a patient, I will close the loop on that when I see the patient.
Yeah, all really well said. I try to avoid going down the pathway of a patient who might be litigious and just stress the fact that I'm really happy to help you move forward. I'm not here to re-examine necessarily. I understand you're frustrated, but let's try to just move forward, and here's what I can offer. And like you said, most people want that. Some people want something different, and I will say I'm not the right physician. And again, age helps in these situations, but I may not be the right physician to you because I'm here to help you move forward, not go back and reassess.
So, any other comments you want to make about referrals and kind of both how you handle them when people are referred to you or versus when you're referring out?
No, just take the high road. Referrals are a good thing, in, out, however you want to think about it. They're a good thing, and community relationships are critically important. And I think we as physicians are becoming more disconnected, and this can only make it more problematic if you let it. And so, just trying to, again, if you can make a phone call, that goes a long way. Or just taking the high road and giving the benefit of the doubt is really important.
So, for the listener that submitted that question, hopefully that helped uh, answer some of your queries. Before we move on to our main topic for the day, I wanted to thank our sponsors at Checkpoint Surgical. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. As a hand surgeon, you know that nerves play a critical role in recovery and function. That's why Checkpoint is dedicated exclusively to advancing peripheral nerve surgery, offering technologies designed to help improve outcomes in the OR.
From handheld intraoperative nerve stimulators to precision instruments and biomaterials, Checkpoint solutions are available to support you. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in hand surgery. Let's go.
All right, you almost got their copyright. They're driving innovation in nerve surgery, maybe some hand surgeries, but definitely nerve surgery. So
Ah,
you were so close
I
there.
was
You were
excited. I got
so excited though.
excited.
I could definitely could see that. So this topic for today came from another survey response, and they wanted to know how we some tips and tricks for the most habitual surgeries. So we thought this would be interesting to talk about some of the more common things that we do, little things that we tell our trainees as we're doing a surgery that might make life a little bit easier. So why don't we start with a mini open carpal tunnel release? So how do you do you have any pearls for, I don't know, room setup, positioning, anything like that?
Yeah, a couple things. Well, one, I had the great question today about laser surgery. Are you going to use a laser for that surgery? I love that question. And I kind of calmly say, no, I don't use a laser. Um, I
We
describe,
should have a laser in the room, like just a laser pointer or something to
uh,
tell people we use the
we use the
laser to
laser.
mark
That's
the
right.
incision. I don't know.
I do a mini open. It's usually a little less than 2 centimeters. And I think the key for me with this operation is I do it exactly the same way every time, from the same retractors, the same instruments, and it is an incredibly predictable operation. This is one of the operations that I think will be done robotically, not by me at some point. I think we're years away from that when we think about how we're going to be replaced, because it is such a, in my mind, if you are, it's still a very quick surgery, but if you go step by step by step, I just think it's a really predictable, straightforward surgery and take no chances.
Yeah, this is one where you know, obviously the goal is to get it right every time. And there's no take no chances, do whatever you're most comfortable with, have your system. This is a case where if you and your team are in sync, maybe no words are spoken during this case because everything is relatively predictable. So, skin incision, I think both of us do the same in terms of using some Sen retractors to get started. As you work through the fascia, you know, the goal obviously is to expose your TCL. Do you have any pearls or ways that you know, do the retraction that will make life a little bit easier?
For me, the most critical, so I always use two Cinerigs, one Ragnell. If a patient's very large, you may need a little more robust retractor to retract the fat. I use scissors, I use a pickup, I use a Raytech. Um, Everything's sharp down to the transcarpal ligament, get it started, and then I finish with scissors. Yes, my key retraction step is to use the sharp end of the Sen rake into the radial side of the transverse carpal ligament muscular area to flatten the carpal tunnel. Because as we know, the carpal tunnel goes from superficial to deep as we travel from radial to ulnar. And if you're not careful, you can miss sort of the
You'll slide
carpal
down the
tunnel.
hill
You'll slide down the hill.
into
And
Guillaume's
so,
canal.
yes. And so if you flatten it, and that means bringing your send rake on top of the thenar eminence and pushing that thenar eminence down to the table, it flattens it out. And I think it makes it a lot easier. I don't know how you think about that move.
Yeah, and I think the exact same thing. So the first thing I tell people is that you want to use the shaft of that sen to rest right on the thenar eminence. So if you position it correctly, the sharp end, as you're saying, you're then going to relax. For those of you on YouTube who are watching, you're then going to take the shaft of that and then use it to push the palm down, the thenar eminence down, so the palm is flat. And that, I mean, because I remember early on in practice, really struggling because I kept letting the palm kept pronating, and I was like, "Where am I going?" And you keep seeing the fat, then you're swimming in Guillaume's canal, and you're very confused. So you have to keep the palm flat. So I totally agree with that. You know, the nice little pearl is that when you kind of see that initial layer of fat, you can use your Raytech and sometimes wipe the Ragnell, use the Ragnell to actually wipe that down, and then you got a really nice exposure. I don't change scalpels until we're at the TCL itself, and I will always use a new 15 blade for the transection of the TCL because that's a for the way that we do it, that's a touch portion of the procedure, and you want to have a nice sharp instrument so that you know you can have the tactile feel.
I love all of that. And when I work, so once we're, again, I think we do mostly the same thing. Once we're in the carpal tunnel, distally. I'll use the knife a little bit, then I'll switch to scissors, carefully spreading above. I don't spread in the carpal tunnel, and part of that is simply because we're doing so many of these wide awake. If you spread in the tunnel and you ding the nerve, the patient gets really unhappy. I do like to make sure there's no scarring between the nerve and the transverse carpal ligament. So work distally until you get that bright fat, and you don't feel any resistance when you lift up distally. And then flipping it proximally, sort of the same thing. I just make sure I have a clean view, and I will say view, not necessarily just palpation, of the proximal transverse carpal ligament and distal antebrachial I guess, forearm fascia, so that you can see a release. And that's basically it.
Yeah, and I've a couple of things that I've found over time, particularly with Wallant cases. I've actually, this is one thing I've changed in the last 5 years. I will use a lot of the baby Army navies. I think are great. The smaller end of it, especially with Wallant, because you don't have the advantage of the tourniquet, and sometimes you have a little bit of that bleeding from the fat. Because it doesn't have the serrations in it, that not the serrations, the openings that the Sen has, it can be really nice to tuck away that fat. You have to be with your smaller incisions. You just have to be careful when you're using your knife deeper because you don't want the back end of the blade to cut the skin inadvertently. So you have to be careful about tipping your blade up and down appropriately to help with that. After I have when I start my TCL, I will divide my TCL as far distally as I can directly visualize. And then after that, and feel safe before, because you're going to have a decent amount before you get to the sentinel fat surrounding the superficial palmar arch. I will then spread a very small spread on top of the TCL so that I can release that last little bit of volar nebrachial or palmar fascia that's going to stop me from parking my ragnell deep. Because if you don't release that last little bit of palmar fascia that you inevitably have not gotten on the way in, it's going to be hard to get your ragnell to sit down deep enough to truly protect you from the arch. So that's one thing that we do. And then I agree with you entirely about not having wide spreads. Wide spreads in general, whether you're in the carpal tunnel or above the carpal tunnel, in the patient that's awake, can be quite uncomfortable. So you have to keep the spreads pretty tight, and I definitely do not spread within the carpal tunnel for a primary carpal tunnel release. And I agree with your pearls about a proximal release. Oftentimes we'll tip the retractors to create a box. I believe that was the Kiefhaber trick. Is that
All of this
is
is the Kiefer trip.
yeah.
Yeah.
So I think I learned a lot about how to do my carpal tunnels from you, Ryan, and Lindley, who all trained in Cincinnati with Dr. Kiefhaber and Dr. Stern. So I don't slide my scissors proximally. I like doing everything under direct visualization. You can see pretty well, and I intentionally in the holding area when I mark my patient, I will write the yes, where basically at the proximal extent of my release that's done underneath, so I can show the patient we're going to do make this incision, but we're going to release back to where the yes is, so you can see we're working a pretty wide area, even though we have a relatively small incision.
Yeah, and I like that as well. And as I think we've talked about on the pod, I draw my incisions in the preoperative area with the patient. I really, really like that. It's a fail-safe against wrong site surgery, and it gives the patient an idea of what they're going to see. I would say this, my last comment, you may have more. My last comment is you outline your incision, you start your procedure, and every carpal tunnel is not the same, even though the steps may be the same. And there are some hard carpal tunnels, which sounds silly to say, and there's some super straightforward ones. Don't hesitate to make a bigger incision if you're not safe. It doesn't make sense. So you make another half a centimeter incision, who cares? And slow down when something feels off, when the anatomy feels off, or there a transverse branch superficial to the transverse carpal ligament. Weird stuff happens, and so yes, you want to be meticulous in your steps and just go step by step by step. But occasionally, you have to slow down, take a breath, and do things differently. So don't be afraid to do that.
I think that's well said. Nothing to add for that. What's your closure? And what do you tell patients about what they can and cannot do after surgery?
Yeah, I've gone back and forth. I have resettled on usually three sutures, 4-0 nylon, horizontal mattress, and a small dressing. I ask them to leave it on for 3 days. They can type or write immediately. After 3 days, they can get wet in the shower. I ask them not to soak it or scrub it until they come back and see me at 12 days for suture removal and initiation of scar massage. I recognize there are lots of different ways to do it. I'm curious as to what you're doing these days, but that's worked well for me.
Yeah, so I moved after visiting friend of the pod, Dr. Moged Terry, in Washington, D.C. I guess it's almost 2 years ago now. I switched to using a dissolvable suture. So I ended up I started with a deep dermal 3 monocrol, but I found that that probably is a bit big for that area. So it's now a 4 monocrol and very specifically on a P3 needle. And that was at the suggestion of a former fellow, Nick Collada. I was not aware of this P3 needle. It's really nice for that small area. And it's a tricky deep dermal to do in the glaber skin. But typically it's about 3 of those, and then 3 deep dermals followed by Dermabond, which obviously it does add an element of cost, at least in the OR, but saves a lot of time down the line in the clinic. And it enables either a later follow-up visit in person or a telemedicine follow-up for patients who don't want to come in if they're doing well. I just ask them to, now in my post-op instructions, it has a little phrase saying if you'd like to convert this to a telemedicine visit or a phone call, just call the office and make sure you send a picture in, which has helped a lot, I think. And it speeds up the clinic assessment because there's no sutures to remove, which everybody's happy about.
Yeah, I love that. I love that. All right, should we change gears? Let's do cubital
Trigger
tunnel real
finger?
quick. Huh?
Trigger
Trigger finger.
finger.
Oh, trigger finger. Sure.
That's a common surgery.
Common surgery.
Not terribly different from what maybe some of the things we do for carpal tunnel, but I think it's straightforward enough where there should be some tips and tricks you could share. So where do you put your incision?
I have changed. I make a longitudinal incision, starting just distal to the distal palmar crease. Obviously, depends on which finger you're working on. I don't cross the distal palmar crease, and it's a little proximal to the palmodigital crease, but it's longitudinal. And I incise only the skin in this case, and then I bluntly spread down to the A1 pulley.
So you said you've changed. What were you doing before you started doing
I've
longitudinal
tried
incision?
transverse and I've tried oblique. I've tried in the DPC, depending on the finger. I just think we want to make this simple and predictable and low risk. And I want to assure that I release everything I want to release and maybe a little extra release, and we can talk about that. I've just gone back. This is what Dr. Stern did as well. I've gone back to a longitudinal incision over the A1 pulley. What do you
Um,
do?
so So I will center my incision based on where the leading edge of the A1 pulley is. So nice percutaneous trigger finger anatomic study that shows that if you take the distance between the palmar digital crease and the PIP crease and extrapolate that distance back, that's going to be your leading edge of the A1 pulley. Now, if that coincides with the skin crease in the palm, I'm going to put my incision there. If it doesn't coincide with it, I'll actually try to do something that's nice and parallel to one of the creases that's close by. And then I have special considerations if it's an index finger or a small finger, because we know that the trajectory of the index finger radial digital nerve and the small finger's ulnar digital nerve is slightly different. It's not straight longitudinal to the rest of the finger, so it's just important to keep that in mind. That's worked for me. And then like you said, straight skin incision, especially for a trigger thumb. For the thumb, I'm typically tucking that into that crease that's at the MP area. But just the skin, and then that's where one use the tenotomy tips to feel down on the center of the sheath, and then a this is where one kind of sort of aggressive longitudinal spread would be super useful. And then have your Ragnell retractors ready to basically park that on the side while you've got everything exposed. And that gets both sides, both digital nerves protected. You're looking straight at the tendon sheath. And then typically, if you place the incision right, you're looking right at the leading edge of the A1 pulley.
Yeah, really well said. And you can use those retractors to actually clean off the A1 pulley. And you can also obviously use a pickup with a Raytech as well. My goal in the release is to release the entirety of the A1 pulley, a bit of the A2 pulley, the most proximal aspect of the A2 pulley, and honestly, some of the PA pulley proximal to the A1 pulley or the A0 pulley, as some people call it. It's not a mandatory thing. It depends on the anatomy, but I don't mind releasing a good chunk of the PA pulley as well, proximally.
Yeah, I'd take all of the PA pulley, and I do take, probably, I don't know, 10 to 20% of A2. Basically, whatever I need to do to make sure that we're not going to have any ongoing and potentially recurrent triggering. So how do you have the patient, if the patient's awake, what do you do? Do you talk to them and show them? How do you handle that?
I ask them if they want to see for certain. I ask them to make a fist. I try to feel directly over the tendons to make sure there's smooth motion, no unexpected catching, no shifting of the tendons too much. If there is tenosynovitis, I'll debride it. It's pretty rare that it's there. Um, yeah, I'm happy to show them or just make sure that I palpate smooth motion.
Yeah, so I before I show them, I talk to them and have them make a full fist and see if they feel like it's catching, and then if it isn't, and then I'll take a new Ray Tech and fold it and place it over the incision, and hold it there with my finger, and then I have them look at it and confirm to me that it's not triggering or catching. And that seems to work out pretty well. Most people don't want anything to do with it, but some people actually want to see the tendon and stuff, and it's a fun little show personship thing to have them do that. What do you do if you notice that there is some ongoing triggering or catching, and you've released as much all of A1, as much of A2 as you're comfortable with, and all of the PA pulley? What do you start to think of the FDS as a slip excision?
Very uncommon, but not unheard of. I don't think going and releasing like the A3 pulley makes a whole lot of sense. So if I feel like there's still some shifting or maybe in a sensation of catching, then I will take out a slip of FDS. I would say I do that once a year in an adult. I do it on every pediatric trigger, but maybe once a year or every other year do I do that in the adult. It's not a big deal. It's quick and it's helpful and it really solves the problem. So if there's any doubt, I don't see any negative in doing that.
Do you do that within the same ex incision?
Yes,
Because there's described techniques to go further out into the finger as well, which can be tricky at times when you've only, planned for local at one site.
yeah, I do it in the same finger. I will aggressively retract or ask the patient to move their fingers to facilitate maximum exposure of the FDS slip, and I think you can get the job done.
Yeah, I think it's relatively uncommon. I think it's more uncommon for me than once a year. I think I've probably done two or three in my first decade of practice. But it is something where you have to be able to think on your feet, especially if the patient's awake. Before we move on to the next one, if the patient's asleep, how do you do your, traction tenolysis kind of thing? I know you have your little fancy baton twirl that you do.
Yeah, yeah, you gotta. It's the hand surgeon trick. You gotta be able to take the small end of the Ragnell retractor and go under the FDS, grab the FDP, and pull it into the wound. And if you can do that, then you're on your way. Can you do that, Dr. D?
You know what? I've done it before successfully, but now that I do so many of these awake, I feel like that's a barbaric technique. No, I never pull it off the way that you do, and I talk about it too. I'm like, I can't do it the way that Goldfarb does, but I do get the job done, and that's what matters at the end of the day.
How do you close these incisions? I use nylon.
Same closure. And then I think the pearl for me is you don't want to learn the hard way. I like putting some web roll tweeners, for the finger because if you don't, that dressing is going to slide its way up the palm, and then they're looking at their incision earlier than they wanted to. That's never a good thing. So the tweeners, I put a couple of web roll tweeners and then take a folded over piece of the web roll or the soft roll, whatever you want to call it, and use that to help secure it. Dressing, a similar protocol to you. Dressing stays on for 3 days. When patients are awake, I like using Coban because I feel I can get a nice little snug fit there. And then I can also tell them, hey, I'm putting it on snug for some compression. You're more than welcome to loosen this if you need to. It sticks to itself. And we give them the extra to go home in their baggie. And we give them a bag of exam gloves to use for the first few days to cover the dressing and keep it dry. Some people do that, others don't. But I think that it's a nice touch to kind of feel like they have a plan. And then as we're closing and as the glue is drying, I will talk to them and give them all their instructions, which I think is nice that they can hear it from me and then hear it from the PACU nurse as well.
Love that. Love that. So let's close it out with another bread and butter surgery, so to speak, dorsal wrist ganglion. So,
Do these bring you joy?
no, I don't think they bring me joy.
But you do them.
But I do them. I think they really make a difference for some people. I'm not sure any of these three surgeries bring me joy. I
No, well, carpal tunnel release, that can get you some hugs in clinic if they haven't slept in a while. You do that,
That's true.
that if you catch people in that sweet spot where it's before it's severe, but they're bothered enough to have it done.
I think
That's
what
a
gives me joy as a hand surgeon is just the predictability of the surgical technique. I think that I mean I'm an anal retentive hand surgeon. I like the step by step that leads to success. I like that gives me joy.
Well, then you should have done total joints. That's step by step in routine.
I
I'd argue
don't
that I love what we do, but I do like, at least in my practice, I think in your practice too, there's enough variability in some of the other non-routine stuff where it does, you need a little bit. I could never only have a nerve only practice. It'd be too much. I need some of the kind of stuff, the quick wins, the feel good moments, the predictability. And it's nice that usually I start the day like that.
Absolutely. Yeah, no, couldn't be a total joint surgeon. No, thank you. So I'll go briefly through what I do and you can add or change. Dorsal wrist ganglion, no matter really where the ganglion is, transverse incision, usually about 2.5 centimeters directly over the scapholunate ligament, especially if it's an occult ganglion, but either way, incision through the skin, blunt dissection. I usually work. Sometimes you'll encounter the ganglion, then I just work circumferentially down to the capsule. If you don't, then I work sort of between the third compartment, the oblique running EPL, and the second compartment, and use that interval to get down to the joint. So that's my initial exposure. How do you think about that part?
Pretty similar. I think this is one of the uncommon ones where pretty routinely it's a transverse incision. For me, relative to other hand surgery things that we do, but I think it does look nice at the end of the day and is appropriate for motion. Um, Pretty similar, I think, getting down, identifying three, four, and two in terms of compartments, and then just working around from there. Because once you've gotten those out of the way, you should be more midline and not as worried about your SRN branches or your DCU branches. Although, as with the initial approach to those compartments, you do have to think about them and just push them out of the way. But then after that, it's kind of open season, right? Like you can move this. This case can take as long as you want it to take. But I think one thing I've noticed is I've become much more deliberate with my decisions as I chase the ganglion, because you can let this thing spread, 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 spread. And the thing I noticed the most with fellows is that and residents is that initially they just spread, spread, spread. And they're like, make decisions, spread, cut, start taking a knife. Because once you've protected your compartment, you're good.
Yeah, there to
You're
me,
safe.
you're safe. There is zero shame if the ganglion ruptures. I don't, doesn't bother me a second. And when I get down to the capsule, obviously you have to protect the SL ligament. But other than that, I take out a segment of capsule. I'm okay taking out a centimeter by a centimeter or even a little bigger. And I think that helps decrease the recurrence. And then you're looking at SL ligament. You make sure you got all your ganglion. Maybe use a cautery to paint the very superficial distal aspect of the SL ligament, and you're done.
How do you think that cautery helps?
I don't know. It feels good. That does feel good.
I tell patients we're sealing off the area, we're zapping it.
The magic dust. Yeah. Um, that's
And then
literally
is
it.
this what's your closure and what's your protocol addressing afterwards?
Yeah, two monocrystal subcutaneous and then subcuticular, a couple of steri strips. I do a splint. I do a 4x15s and a wrist splint. Someone could convince me to stop doing that, but patients are pretty sore, and the old mojo that maybe it decreases recurrence. I guess I buy it. I see them at 12 days and let them take off however they desire.
Yeah, pretty similar with the closure. The exception is I do a big bulky soft dressing. Just I tell the trainee set it up like you're going to do an old school Goldfarb style splint, but just don't use the plaster. And then I let the patient take the dressing off at 5 days and switch into a cock-up wrist brace.
So every patient gets a cocker wrist brace?
hmm I have them go either our ortho DME office brings it over, or if I remember ahead of time, I'll give it to them in the office before surgery. So that way they have it already, and I tell them, hey, just make sure you have this at home. Or the PACU will call the ortho office and get a wrist brace.
And are you derma bonding?
Depends on how patient I am.
Yeah.
If I will Durabond or just Steri-strips. I don't feel as strongly about this one.
Yeah. Interesting. I don't think I've ever regretted a splint, but I like your technique. I may have to try it. And I find that most patients don't even want a splint at the 12-day mark. Some do, and I'll give it to them, but most just want to kind of ramp up and go.
Yeah, I think it's nice. I mean, everybody feels more human with the normal shower. I probably could just move them to that at 3 days, but I feel like somewhere in between and a little longer for things to quiet down, given that we were working at the joint capsule.
Yeah.
So if you are a listener and you have other relatively common surgeries, you want us to talk about tips and tricks, and certainly we welcome tips and tricks from listeners because I know that many of you have your own, and you may completely disagree with the way that Dee and Goldfarb do it. So please let us know.
Yeah, teach us something. We are all ears. There are definitely different ways to accomplish these goals. That was fun, as always. It's great to catch up.
Yeah, absolutely. So send us some suggestions, handpodcast@gmail.com. And always leave that review. Helps us get the word out. 5 stars only.
Awesome.